Good afternoon. First of all, I thank Pune IAP for giving us this opportunity to host and kind of moderate this very important session on pediatric epilepsy seizure disorder. We are trying to cover a really extensively vast topic, and I will try and finish up we have got about 6 cases in the whole presentation, which will be going by section wise, and we have got really very learned faculty here, so I am sure it's going to be a very crisp, very practical take homes to each of it. We'll try not to indulge into any theoretical details. We'll try to make it as practical as possible. So we too will be alternatively taking cases. We'll be focusing or kind of guiding individual questions to each of the faculty, but others have some extra ideas or some different way of thinking, then definitely we can part. But see, let's try and finish the whole thing in 40-45 minutes that's been allotted to us. Let's keep the ball rolling. I'm sure all of you know that neurological emergencies are quite common in pediatric OPD or emergency practice, and more so in case of seizure, others being maybe altered child or unconscious child. But this is one which is published from our part of the nation or from the world, which is in European Journal of Epilepsy, not very old paper, just in April 2025, which says almost the overall epilepsy prevalence in India is 0.8%, with the zonal prevalence north far more than the central zones, and community studies showed higher prevalence in this. And I'm sure all of you must have seen so many febrile seizures and primary kind of without any seizure, without any previous history and those kind of things. So we'll start rolling ball with the most common one. So this quiz starts with Dr. Abhijit. So here is a 1-year-old child who is 10 kg and who is brought with a typical febrile seizure. So fever since one day with a cold and cough and seizure lasting for about 20 minutes. And then emergency, he is brought to us. He started with emergency care with oxygen, and then nasal medas given, no response in 3 minutes, so Loraz is given to him, and seizure stops. And this being a first episode of seizure. So typical case of febrile seizure. So the first question goes to Dr. Abhijit. What is typical and what is atypical febrile seizure?
Yeah, so this is our conventional pediatric teaching that we know typical, now the simple febrile seizure is nomenclature. So typically what we say 6 months to 5 years, 1 seizures in 24 hours, so non-focal, and definitely it is like without, in absence of CNS infection and with the underlying. And of course, I being pediatric neurologist would like to add, this is a diagnosis of exclusion. So many times like some encephalopathy in these parts are there, and like many times couple of symptomatic febrile seizures are labeled as simple febrile seizures. So it is something I have to add on this
why
question.
you want to differentiate typical or atypical? Really it does make a difference?
Yeah, means it makes different because typical, as name says typical, it's very common. So again, as a when you want to prognosticate particular thing, then it makes difference, because if typical febrile seizure is there, you can always assure the parent that it's like a common thing with fever. But atypical, as Abhijit was saying, that sometimes CNS issues can be there, or maybe encephalitis or something. We will have to rule out certain things.
So what are those atypical features?
Atypical feature is a prolonged seizure. Again, the definition kind of changes, but overall, if we can say that it's more than 10 minutes, then more than 2 seizures within 24 hours, and focal seizures. So these are the atypical features.
Does the age make a difference to label it as typical or atypical?
Yes. Usual age for febrile seizure, what we consider by definition, is from 9 months to 5 years. Few papers have mentioned up to 6-7 years also. So if it is early, very early onset, if it is less than 6 months, or very late, maybe after 6-7 years, that is also one thing we might consider that some are typical.
So somebody comes at 3 months with a seizure.
Yes.
The baby comes with 100-degree fever and 3 month fever. Do you straightway label him as atypical?
No, not in that way. There should be the other. This is just one pointer. It could be, but typical age, like most of the common presentation of febrile seizure, is 18 months. Usual definition is from 9 months onwards. Why this age is important? You need to be more vigilant because they may not have the deficit, they may not have the symptoms. So here you will be, for investigation purpose, you will be on the scale on the higher side. At even low suspicious, you will start investigating. Because the problem with febrile seizure is why this definition is there, because if you are very sure that it is typical, you may not be that aggressive for investigations. But if you find some atypical, still it can be febrile, but here you need to be vigilant, if required, investigate.
Now, this child has come with like a typical febrile seizure. So, beyond this, do you want certain history to be confirmed, or certain features as a background history which will be heading towards likely red flags going for further? So, are there any few histories you want beyond this primary?
So definitely yes, as I said, I mean this, even the typical or simple febrile seizure evolves. So we need to see that particular episodes as well. And as well as we know preterm, prematurity, NISU graduate, some development delay, even subtle, not necessarily very, a strong family history, which is again kind of a go in favor or kind of a refute the simple febrile seizures, and any focal deficit. And on examination, if you find some kind of a red flag signs, then definitely like macrocephaly, few neurocutaneous stigmata. So those are something which will definitely take me away from the simple febrile seizure.
Dr. Patil, which investigation you want the general pediatricians to do if he comes as a typical febrile and atypical febrile? Let's talk about febrile. Do you really want me to do it, and which one?
So, in a typical febrile seizure, there is no CNS infection as such, okay? There is infection source is somewhere else. So obviously you need investigation to look for that infection source, so the routine blood investigations and all those required. Obviously the question comes to mind whether we should do electroencephalograph or not, EEG or not. Again, if you are very convinced there is simple febrile seizure, no meningeal signs, no red flag signs, as Abhijit was saying that someone is having microcephaly or focal deficits, then you need not do anything, you just need to observe the child. But obviously, in atypical febrile seizure, if you are 2 or 3 seizures within 24 hours, focal seizure, prolonged focal seizures, early onset, neurological examination which showing some red flags, then you definitely require investigation. Probably you can have higher suspicion and get at least EEG done in those patients and look for any abnormality. I really won't go for imaging initially, but obviously if you have something to add on, suppose you feel that it looks like a meningitis or looks like an encephalitis, then obviously imaging also will come in picture, but that will be like a clinical discretion. So normal typical febrile seizure doesn't need all these things.
3 decades ago, 35 years ago, when I passed my MD, then used to be first febrile seizure, lumbar puncture must. What's the status today?
Yeah, so meningeal signs, if typical febrile seizure and no meningeal signs, obviously if age group is not fitting, then probably we'll give for a CSF and lumbar puncture, otherwise we won't.
Any role? Yeah.
I'll like to add, sir, this, the message from this is that the presentation can be anything, but in typical febrile seizure, on examination, I think 3-4 points are very important: history, examination, and observing the child. If any child with febrile seizure, within 1 hour, if it is back to his pre-seizure status, clinically, most of the time, these don't require any investigation.
Wonderful take home, I suppose. This is a very
because
good
this is very common in
conversation.
pediatric practice. In the middle of the night at 3 o'clock, they will come, you will start thinking encephalitis, meningitis, whatever it is. You will spend your half night, next day morning the child is playing in the ward. So this is a typical history, because nobody in the world and not a single investigation is there which can tell you at the presentation whether it is encephalitis, whether it is a genetic epilepsy, whether it is a febrile seizure. So I think if within 1 hour, if the child is normal, playful, it's a febrile seizure.
Absolutely. Coming to the
And
last,
definitely
very
don't
important-
add on the husband of EEG and MRI, because that sedation itself, you don't know what is the level of encephalopathy the child really goes into. Because that is something which can kind of overdiagnose that encephalopathy when we give sedation and other things as well.
Perfect. Last, very important, controversial topic. Preventive anti-epileptic drugs in febrile seizure. Any one of you can take.
As per guidelines, you don't require any preventive medications. So again, we had a lot of debate at a national level as well, and most of the guidelines says no role of any anti-epileptic drug or anti-seizure medication. Obviously, when at a national level we discuss this issue, and we have this practice of giving clobazam as a intermittent prophylaxis. There has been studies with a continuous prophylaxis and intermittent prophylaxis, and it has been shown that it's not useful. Okay. Again, what this intermittent prophylaxis does is probably reduce the anxiety at parental level. So that's what being observed. So in I think one of the IAP guidelines we spoke about it.
So this is Cochrane 2021,
Yeah.
which is clearly stated there is no scientific role in short-term or long-term preventive of this. But I am sure, what's your practice? All of you.
Apart from midazolam, I think apart from clobazam, I think we should encourage, if at all there is a prolonged atypical seizure or prolonged seizure, use of midazolam spray. That is more useful than intermittent clobazam.
Poking a bit more, what's your practice, all three of you?
So what I would see is definitely socioeconomic background of the patient. Complex febrile seizure, the person who's staying in far off farms, the medical facilities are not close by, recurrent seizure, and then I know definitely even in our scenario, the kind of well-educated people even doesn't know how to administer midazolam spray. All these studies which are coming from the West, where FEPSA study and all these things, when they know how to give interval, and then what we know is like definitely time is a break.
Single word, do you give Clobaz?
Sir, for simple febrile seizure, there are no indications, but important thing, you have to take the call in parents' perspective. There is lot of parental anxiety when they are seeing febrile seizures. So if they are convinced simple febrile seizure don't require anything. But we have to consider this, that most of the admissions in peripheries are because of the febrile seizures. So if you think that this child is not having medical health facility nearby, if the parents are very anxious sometimes, we take a call on that, because 2 days frisium is not a big deal, giving half tablet in the morning, half tablet in the evening. Because many times, because of this fever and a simple febrile seizure, they are getting admitted and spending thousands of rupees on that, which is not required. So if you are able to prevent this, so this call has to be taken by the pediatrician. You should think that simple febrile seizure is not needing any prevention. But from where he is coming, what are the background, what are the health accessibilities there?
Very interesting. IAP guideline says frequent seizures, that means more than 3, need to be given long-term continuous prophylaxis.
No.
I remember there was one guideline stating that. Any role?
No.
More than 3 or 4 seizures, more frequent febrile seizures?
It is more clearly if it is more than 3 episodes in 6 months. 6 months is very important.
So then you will give?
Then sometimes
How
you
long?
give 1 or 2 years. Sir, again, it is not a guideline, sir. It is something which I have to take. 3 times the child is admitting.
Suggested.
So in these cases, sometimes.
I'll just add, because these guidelines has been made by ILE, International League Against Epilepsy, the Cochrane review and all. So what happens typically if someone in US or UK or in Europe has a seizure, the paramedics will reach within 5 minutes or 10 minutes maximum. So they get attention. Now in our scenario, if suppose someone is in tribal area or in a Pune also far away, reaching to the health facility is really difficult. And not every febrile seizure will go on to have febrile status epilepticus. But someone has gone into febrile status epilepticus, that is disastrous. So again, by doing virtue of like intermittent prophylaxis, probably that might go down. Definitely, if you prescribe midazolam with atypical febrile seizure, it will definitely go down.
Just last question related to febrile seizure. The same child with a typical febrile seizure comes at 6 or 7 years with next episode of febrile seizure. Now he is beyond that age. In the typical period, he had about 3 or 4 episodes. Now after a break of 2 years, at age of 7 years, he comes with a febrile seizure, a typical presentation. What is your response? What do you do?
So I'll again talk to the parents. I mean, if there is strong family history of febrile seizure, I'll say he may outgrow, but there is high chance of recurrence and there is high chance of febrile seizure. So definitely he need to be in supervision.
You investigate this patient, you give long term,
Long-term IEDs, I'll discuss with them. So usually I won't. But if, as I said, I mean, he's the kind of a parents are working, he's only child in the school, I mean, home and all these things, I may tend to err on kind of giving the treatment, or mainly I would say he will just wait and watch, but first aid and entire thing should be with them. If it is a brief
This
seizure.
particular patient, you are not done in investigation in the past. He comes at 7 years with febrile seizure. Now, are you going to do any investigation, EEG, imaging, anything? Because he has beyond the range now, beyond the age.
Strong families with febrile seizure, I'll bit.
Okay. You have any other?
Post-COVID, sir, we are seeing patients up to 8, 9, 10 years, they are presenting with fever and like a febrile seizure. Initially, we used to investigate them immediately after post-COVID, but nowadays with confidence, we are seeing presentations even at the latter age. So again, on the low threshold, we will not investigate much. It depends on the situation.
Just to add on, basically why febrile seizure goes at 6 years of age. It's because the brain's maturity or brain sensitivity to fever goes down, and it can be different for particular individual. It can be like some for individual, it can be 7 years, 8 years now. As long as everything is fine, neurological examination files, development is good, then we can wait.
Perfect. Now let's go to the
One
second
more thing
case.
is, now we all know it's SCN1 mutation, which has variety. I mean, somebody will have febrile seizure, somebody will have complex, somebody will have JERS plus, somebody has Dravet's and all these things. So we don't know which patient will get into it. So time itself will kind of unfold what is the kind of story of that particular patient.
Audience must have realized the faculty are so knowledgeable, they know so much. It's going to be difficult to finish in 40 minutes, but we'll try and do that. But try to let us become more precise so that, because really a lot many things to do. I'll move to the second case. Dr. Kankaria will take over, please.
One last thing about this case. Actually, if you look at and ask the pediatrician, most of us probably end up giving clobazam. If I ask show of hands, I think probably everybody will pick up. So why, and practically speaking, we all feel that it does make a difference probably. Can we just have a show of hands? Do you all feel that it does make a difference, clobazam? Does it make a difference? Yeah. So
Yeah, but it's kind of difficult to make a study and prove it.
And
Because not
do you-
every fever will give febrile seizure. So how will you prove it?
And do you recommend fever prophylaxis, like do you recommend paracetamol, sponging and all that stuff to the parents to keep them busy? So whether that also makes a difference, that again, I think we all pediatricians always, whatever we say here, but we all pediatricians ask them to give paracetamol.
That will make the child comfortable, not the seizure prevention.
No, so, fine. Let's now go to the next case.